Hi, everyone. Thank you so much for joining for eVox Neuroscience Lunch and Learn on recognizing ADHD. I just want to check and make sure that everybody can hear me loud and clear. So if you wouldn't mind using your GoToWebinar dashboard menu, and in the question section, just shoot me a question or a comment, letting me know that you can hear me, and then we can go ahead and get started. Perfect. Thank you. Getting some responses rolling in. That's awesome. So now you guys know where your question box is. So if you have any questions throughout the presentation, go ahead and shoot me one. If I don't get to addressing it during the presentation, I'll be sure and send you an email afterwards so we can clear anything up or dive into any subjects further. So if you've joined us for Lunch and Learns before, welcome back. If this is your first one, I'm so excited you're here. My name's Morgan Edmondson. I'm the Medical Affairs Manager at eVox. And today we're going to be talking about using brain-based biomarkers to recognize signs of ADHD. So our learning objectives for today is to strengthen your understanding of functional physiology metrics and learn how to recognize key biomarkers of ADHD. So at the end of this presentation, hopefully you'll be able to describe changes in reaction time variability associated with ADHD. That's a new biomarker we'll be talking about today. Describe changes in the P300B waveform associated with ADHD. If you've attended our webinars in the past, you should be a little familiar with P300B, but we'll go ahead and review it again for you today. We want you to interpret database comparison EEG head maps and recognize changes related to ADHD. We'll be defining the theta-beta ratio. That's another metric that might be new to you that we'll be reviewing today. And in the end, we want you to be able to use electrophysiology data to develop an ADHD differential diagnosis and develop treatment strategies. So starting off with how we traditionally diagnose and treat ADHD. It's defined by persistent and age-inappropriate patterns of inattention, hyperactivity, and impulsivity. Usually it's diagnosed in early age. A study of 807 participants with a lifelong diagnosis of ADHD found that 45% of those participants were diagnosed at a very early age, less than 7 years. So if you're looking to diagnose and treat ADHD, chances are you're working with a child. It's estimated that ADHD affects about 8 to 12% of children worldwide, and the prevalence in adults is about 2.5%. And diagnostic criteria are based on 18 descriptive symptoms. But there's a very high comorbidity with other psychiatric and substance abuse disorders. So this can make diagnosing ADHD a little bit tricky because it can also present with depression, anxiety, conduct disorder, things like that. So teasing out the different subtypes of ADHD to other potential disorders can be a challenge when you're just using these descriptive symptoms. And it's most commonly treated with methylphenidate, like Ritalin, but about 30% of patients don't respond to psychostimulants. So a couple problems with the current situation. First, our diagnosis is based on patient symptoms. It's based on these 18 descriptive symptoms, and it can be difficult to tease out ADHD from other psychiatric disorders. Second, not all patients respond to psychostimulants. So if you have a patient that's not responding to methylphenidate, how do you treat that patient? So this is a quick case study, a 14-year-old male coming in with defiant and irritable symptoms. On a neuropsychological screener, he's marking that he has most of his symptom complaints in this executive and attention domain. Now, that's pretty common for somebody with ADHD. So just based on symptoms, this does appear to be an ADHD case. But to really know what's causing the symptoms can be challenging. You're just basing it off the patient's self-report. It could be ADHD, but it also could be something like anxiety or depression. And if it is indeed ADHD, we want to know if this patient will respond well to psychostimulants, right? We can always do the guess and check, but it would be better to objectively look at the brain, see if this patient is a good potential candidate to have psychostimulants and respond well. So that's why we use objective electrophysiology in order to make this differential diagnosis and plan our treatment approaches. So functional neuroimaging via EEG is well-established, non-invasive, affordable, office-based method of brain imaging. And these objective measurements don't rely on patient self-reports. So we're looking at the brain itself. We're cutting out our reliance on just patient symptoms. And there's a lot of research-backed electrophysiology metrics that correlate to ADHD. I did a quick Google Scholar search of EEG and ADHD and got over 40,000 results. So there's a ton of information out there. It's been very well studied in clinical research. And I'll note that biofeedback can be used to target and correct brain imbalances correlated with ADHD symptoms. So I'll talk a little bit about biofeedback at the end of this presentation and how it can be used to treat ADHD as kind of an alternative method to psychostimulants when you get a patient that isn't a good potential responder to that approach. So key biomarkers correlated with ADHD we're going to be walking through today. First is actually a behavior metric called reaction time variance. Second is our event-related potentials, specifically the P300D component. And third is our resting state EEG. We're going to be looking at head maps. And there are actually two kinds of ADHD we're going to be looking for. One presents with excess theta, so high power in the theta frequency band. And the other presents with excess beta, so high power in the beta frequency band. We're going to walk through what all of this looks like. So starting off first with behavior metrics and reaction time variance. The technical definition for this is intra-individual inconsistency in performance. It's kind of a beefy definition, so let's break it down. Intra-individual, so you're looking at one person alone, so one patient. Inconsistency in performance. Are they responding well and very reliably and consistently, or are sometimes they right on the money and sometimes they're totally off? So how consistent is this one patient in their performance? And we measure this during a go, no-go task. And this is what the eVox system uses as a go, no-go task. It comes with a set of 4 stimuli. The first is a large circle. That's the go stimulus. So when a patient sees this, they're pressing a button as fast as they can. And when a patient sees any of these other 3 stimuli, they are not pressing a button. They are not going. So those are the no-go cues. Hence, go, no-go. And typically we calculate reaction time variance as the standard deviation of reaction time, or sometimes the standard error of reaction time. So it's not reaction time in itself, it's how varied you were in your reaction time. And it's kind of assumed that an increase in reaction time variance reflects occasional lapses in attention. So a patient is working really hard at this task, responding only when they see the go stimulus, and then they have a lapse in attention, and then they're really delayed on one of their responses. And then they click back in with their attention and they're right on the money. So that's how this ends up being very varied. So when we talk about reaction time variance and its relationship to ADHD, a good classic study was by Mueller in 2011, 75 control patients, 75 ADHD patients, and they looked at reaction time variance. Here we have the standard error of reaction time on the x-axis, and we measured that for controls and ADHD groups. And we saw that reaction time variance was significantly higher for the ADHD patients compared to controls. Now, interestingly, when they looked at reaction time itself, so just how fast were patients pressing the button, ADHD patients performed comparably to controls. So it's really the variance that's higher compared to just the reaction time itself. And this graph kind of helps us conceptualize why that is. So here on the x-axis, we have reaction time in milliseconds. And on the y-axis, we have the number of trials. And this green wave is showing us our database norm, so where our patient should ideally be. And our black bars are showing patient responses. So this patient is primarily responding within the database norm. But there are a couple of these responses that are way out here. It took him a lot longer to respond to the go stimulus. And these reflect attention lapses. So you can see that our variance is going to be a lot higher compared to our database norm. But overall, our reaction time, when you average it out, is pretty similar. This black arrow is our mean reaction time for our patients, and the green dot is the mean for the database norm. So reaction time is similar, but the variance is a lot higher for ADHD patients. So when we look at reaction time variance and the report, we're looking for increased variance. So it presents like this under our behavior metrics category, reaction time variance. We get a result and we get a reference range. So typically we'd like to see variance less than 10 milliseconds of standard error of reaction time. And a lot of times ADHD patients will have a lot higher variance. This is an example of 144. You can very clearly see that's outside of our ideal reference range. Now, I'll note there are a couple other behavior metrics called omission and commission errors that ADHD patients will frequently score high on. Omission errors means the patient missed the go target. So they were supposed to press the button and they didn't. And that reflects inattention. They weren't paying attention to the task at hand. They just totally missed the go stimulus. Commission errors mean they pressed the button on the no-go target. So they weren't supposed to do anything, but they got too excited and they pressed the button anyway. And that can reflect impulsivity. And it's pretty common to see these scores high for ADHD patients as well. Now, one note that I will make is if you're testing older patients, sometimes, and not necessarily ADHD patients, just any patients that walk into your office that are considerably older in age, our commission errors can be high for them. And that might reflect that they didn't understand the task. So keep an eye out for that. If you're seeing commission errors 50% and above, they probably didn't understand the task, and you'd want to potentially retest, make sure they got it, or just kind of take the behavioral metrics with a grain of salt in that event. Okay, so moving on to our second biomarker, we're going to talk about event-related potentials. So event-related potentials, or ERPs, are an EEG-derived metric, and they reflect brain processing speed. So technically, the definition is a time-locked neural activity related to sensory and cognitive processes. But basically, it's measuring how fast the brain responds to a stimulus onset. So here on the x-axis, we have time, and on the y-axis, we have voltage. So how many neurons are powering this response. And here we have the stimulus onset, and then we see this very clear waveform with different labels on peaks and valleys. And that's because there are different components to our overall ERP waveform. Now, the naming convention for these components is either a positive or negative voltage, so P or N, and then the latency time where this component usually occurs. So 1 is around 100 milliseconds, all the way through P3 is a positive voltage around 300 milliseconds. So from that definition, you should be able to derive we're interested in two factors for ERPs. We're interested in speed or latency. When is this component occurring? 300 milliseconds, or is it later than that? Is it at 400 milliseconds? And then we're also interested in power. And power really reflects how many neurons are successfully working together to recognize and process information from this stimulus onset. So power, remember, we're interested in positive or negative voltage. And really, the higher up we go or the lower down we go, the better. We want to have really high power. It means our neurons are working together in unison to process this information really efficiently. So when we interpret ERPs, we are interested in those two factors. Here on the x-axis, again, we have speed, y-axis is power. our blue line is our control subject, and our orange line is an early frontal-temporal dementia subject. So first notice that our dementia subject has significantly delayed speed. The peak of their ERP waveform has shifted far out right. So really we'd like to see this peak around 300, but this subject is about 675. So they have really delayed speed. And when we look at how it shifted on the y-axis, we can see that our dementia subject has significantly reduced power as well. They've shifted down on the y-axis. Their neurons aren't powering up together to process information. Now, sometimes when you're reviewing ERPs, you might see an indiscernible result. That means the ERP was too slow or didn't have enough power to be detected. And this example is a case of not enough power. Instead of seeing kind of a flat line and then a big peak like we do over here in our blue for our control subject, it just kind of flatlines the whole way. So that's a case of not enough power. Sometimes we'll see a peak, but it's way far out here. And that just means we can't even trust it's the right component because it's occurring too far away from where it should have. So we talk about ERPs and its relationship to ADHD. We're really interested in the P300 component, and there are actually two subtypes of P300. P300A is what we call the attention component, and that's really attentional capacity. And then P300B is our working memory component, which is sustained attention. So in eVox reports, you'll see P300A and attention, and then P300B and working memory. So your first inclination might have been, oh, P300A is going to be affected for ADHD patients because of that attention factor. But actually, studies have shown that children don't suffer from a shortage in attentional capacity. It's that they have a dysfunctional engagement operation. So this engagement operation is associated with combining all brain resources in order for an action to be accomplished. So that's actually related to our working memory sustained attention. And so we're interested in our P300B component. Now, decreased P300B, meaning reduced power in P300B, so shifted down on the y-axis, is very well studied in ADHD. It has a very robust observation that ADHD patients have decreased P300B compared to controls. And these are just some visual representations of how that looks on a head map. For here on the left, on the left we have control subjects, and P300B occurs back here toward the back of the head. And you can see lots of power here. The brain is firing up and processing information. And for the ADHD combined type, we don't have really a response at all in the 8 to 10 years range. And then 14 to 16-year-olds, we have some response, but not as strong as controlled. So that's just a visual representation of what decreased P300B looks like. Now, ERPs and the report will be displayed like this: our ERP waveform, a result for speed, and a result for power. So for ADHD patients, you're really looking for reduced P300B power. So sometimes it will be red like this, meaning, yep, we're letting you know this is a really low power, pay attention to this. But sometimes it won't be red. Maybe it'll be 10 and it's not highlighted in red, so you think it's okay. But really what you should be doing is comparing P300A power to P300B power. So you're looking at the difference between our A and our B. So here we have 15, right? So ideally P300B is also about 15. That's a healthy power. We'd like to see it approximately the same in each of these components. If you ever see that P300B is less than 50%, that's clinically meaningful. And I'll talk about this again when we go through some case studies. There's an example where a patient has a power of about 40 for their P300A and then drops to 20 for their P300B. So it's not marked in red for the P300B because technically 20 for a normative database is an okay power. But for that patient, it's really low because for that patient, their norm is about 40. So hopefully that makes sense and I can talk about that more after the presentation if desired. Okay, so moving on to our quantitative EEG, our last biomarker. So EEG measures electrical activity of the brain, and we're interested in two factors: frequency, which is the speed of brainwave, and power, which is the amount of activity within each frequency. So starting off with frequencies first, brainwaves reveal different rhythms created by neural communication, and frequency is kind of the name for these rhythms, and they're measured in the number of cycles per second of the brain's electrical activity. And cycles per second is hertz, so frequency is a number of hertz. So here are some graphs of our 4 frequency bands. So delta is our really slow frequencies. There are not very many cycles within a second here. Theta is a little bit faster. Alpha is kind of our resting state, normal brainwave, and beta is our really active, fast brainwave activity. Now, if you have attended these lunch and learns in the past, you should remember that we care about frequencies and the speed of frequencies because they correlate to different behaviors. So slow frequencies are related to slow behaviors. Delta is related to deep sleep. Theta is related to feeling drowsy or daydreaming off in la-la land. And fast frequencies are related to fast behavior. So beta is really active, you're concentrating, you might be hyper alert. Okay, so power is the amount of electrical voltage present within each frequency. So I want to note that all frequencies are generated in the brain at all times, but it's the amount of each frequency being produced that changes depending on what the person is doing. Right, so we measure the amount of each frequency in terms of z-scores. How many standard deviations away is my patient from the norm? And we color code this with the rainbow. So blue means low power. My patient isn't having enough neural recruitment to produce this specific frequency. And red is high power. My patient has too much neural recruitment and is producing too much of this specific frequency. So when we look at our head maps, we have frequencies that represent each head, all the way from 2 through 30. And we always ask ourselves, what frequency are we looking at? Is it a slow frequency in like the 2 to 10 range, or is it a fast frequency, the 10 to 30 range? Next, we ask, what's the power? Is it low power or high power? Is my patient making too much of this frequency or too little of this frequency compared to a normative database? Now remember, we're comparing this to norms, so ideally we'd like to see green in all frequencies. Green would mean that my patient doesn't significantly differ from a controlled database. And finally, we're interested in what brain region our dysfunction is in. Now, this is really important when you're considering patients with potential ADHD, because it can give you insight into different endophenotypes or different subgroups of ADHD. And it can also be used to guide treatment strategies. So is this patient going to respond well to stimulants, or should I take a neurofeedback approach? Okay, so let's break down our different endophenotypes for ADHD. Now, endophenotypes, basically just think of it as a subgroup of ADHD that presents with different brain patterns of activation. So our most common subtype of ADHD is called excess frontal-central theta. Let's break down what that means. Excess means high power. I have too much of this stuff. So I have excess of this. Frontal-central means I'm going to be looking central and frontal in the head. And theta means I'm interested in the theta band, 4 to 8 hertz. So when I look at my head maps, I'm interested in 4 to 8 hertz. I'm interested in high power, and I'm interested in the frontal-central region. So this is a great example of excess frontal-central theta. Now, in a meta-analysis of 9 studies that collectively looked at almost 1,500 subjects, the average excess in the theta band was 32% for ADHD children compared to controls. So this is a really robust finding. This effect size was quite large, and it has a really high sensitivity and specificity. So if you're seeing this, chances are it's ADHD, of course, if you see other biomarkers with it as well. You never want to rely on one biomarker in isolation, but this is a really robust finding for ADHD children. Now, oftentimes when we see this excess frontal-central theta, we'll also see a really high score on theta-beta ratio. Now, this theta-beta ratio is an FDA-approved measure for attention disorders. And it's just looking at the ratio of power in the theta band compared to power in the beta band. So it's the ratio of slow waves compared to fast waves, because remember, our theta band is here in our slow waves, and our beta band is here in our fast waves. Now, when we look at the theta-beta ratio for ADHD patients, it's pretty consistently higher than our control group in this study. And this 1999 study was kind of one of the pioneering studies for theta-beta ratio and its relationship to ADHD. And we see that the inattentive type of ADHD and the hyperactive combined type of ADHD were both significantly higher than controls across all ages. So starting at age 6 all the way through age 30, we can see that our ADHD group has high theta-beta ratio. And a sensitivity for this calculation is 86%, meaning the amount of ADHD patients that are going to score positive on this, so they're going to be high. And the specificity is 89%, meaning the percentage of non-ADHD patients that will score negative. So very good specificity and pretty good sensitivity. And I'll note that the critical values for ADHD on the basis of power ratios, meaning on the basis of the theta-beta ratio, changes according to age. So there are different age ranges as established here, and our norm for each age changes, right? So somebody with a high theta-beta ratio when they're 6 is going to be different than somebody with a high theta-beta ratio when they're 15, right? So we always need to reference back to what the norm is for the age, because even controls will decrease in this ratio over time as they age. A couple things to note here is that not all subtypes of ADHD will have a high ratio. So remember this sensitivity score of 86%, that means almost 15% of subjects with ADHD won't have a high ratio. And that's okay. We're going to be talking about a different brain profile to look out for ADHD. And another thing is that this endophenotype responds well to stimulant medication. So if you see a patient that has the excess theta biomarker and a high theta-beta ratio, they usually go hand in hand, then that patient might respond well to stimulants. Now, in contrast, let's talk about the excess beta endotype. This is a small subtype of ADHD, about 10 to 15%, that presents with excess frontal beta. So remember that excess means high power. I have too much of this. I have excess of this. Frontal means I'm looking at my frontal electrodes. And beta, oops, I forgot to move my red box, but beta means these high waves. It should be over here in the 12 to 30 range. So when I'm looking at beta, I'm looking at my fast frequency waves. I'm looking for high power, and I'm looking for a frontal location. So this is an example of excess frontal beta. Now, this was a study of just comparing a control group to an ADHD group, looking at the power of the beta band in the frontal region. And across different ages, our ADHD group has significantly higher power. So that's just some quick study to back up this excess beta endophenotype. Now, typically this excess beta phenotype comes with what we call beta spindling. So beta spindling you can pull out of raw EEG data, and we're looking for really dense cycles, and that's our beta, right? Remember, beta is fast cycles, fast, really dense, dark cycles, lots of cycles per second. So we're looking for these little dark squiggle lines. That's called beta spindling. And usually our excess beta ADHD subtype comes along with beta spindling, just like our excess beta usually comes along with a high theta-beta ratio. Now, something to note, this excess beta subtype is a small percentage of ADHD cases, but 10 to 15% will still occur. And it's important to keep an eye out for this because this endotype does not respond well to stimulant medication. So these patients with ADHD of the beta type typically won't respond well to stimulants. It's not going to alleviate any of their symptoms, and a different approach would probably be better, something like neurofeedback. Okay, so QEEG and the report, what we're looking for. Type 1 is our excess theta. We're looking for too much power in the theta band in the frontal-central region. And usually it's coming hand in hand with a high theta-beta ratio. Or we're looking for excess beta in the frontal region. And usually it's coming hand in hand with beta spindling. Now, I'll note there's a lot more you can read about these different patterns of ADHD presentations in the brain. There's a great review article you can look up for further reading if you're interested, but this is kind of the distilled message of it, just kind of what to look out for when you're going through eVox reports. Okay, so a quick summary before we get into case studies. Our first biomarker was behavior metrics reaction time variance is what you're looking for, and you're looking for an increased reaction time variance. And sometimes you'll also see an increased omission or commission errors, or both. Second, you're looking for the P300B component of ERPs. You're looking for a reduced P300B power. And finally, when we look at our head map, you're looking for high power frontal-central theta together with the high theta-beta ratio, or you're looking for high power in central beta with the beta spindles. So those are two main profiles that you can see, and it kind of helps you differentiate what patients are going to respond well to stimulants and what patients aren't. So speaking of treating ADHD, as we mentioned at the beginning of the presentation, methylphenidate is a psychostimulant that's typically used to treat ADHD, and this can actually decrease reaction time variability. So when it's given to children with ADHD, their reaction time variability actually decreases, so they perform comparable to norms. It increases their P300B power. Now, I'll note it doesn't increase their P300A power, because remember, it's really this working memory P300B component that is affected in ADHD. And it's typically effective for our excess theta type of ADHD. Remember, that is the high power in the frontal-central theta and high theta-beta ratio. Now, in contrast, it's not effective for other endophenotypes, and that's about 30% of our ADHD population. So we want to keep an eye out for this opportunity for a differential diagnosis of what type of ADHD does this patient have according to their objective brain biomarkers. So biofeedback is an effective intervention for ADHD, and especially for the beta subtype of ADHD that doesn't respond well to stimulants. And devices like eVox can provide easy to use biofeedback designed specifically for the individual patient. So eVox can help physicians target training based on their biomarkers, and it can also train suboptimal regions that might be associated with clinical symptoms using neurofeedback. So just an alternative to methylphenidate for those patients that you can look at their biomarkers and right off the bat tell they're not going to respond well biofeedback and neurofeedback could be a really great treatment option. All right, so wrapping up with a few case studies. This is a report of a 20-year-old male with attention complaints. So let's walk through our biomarkers. So first, I'm looking at our response metrics, and sure enough, I note that this patient has high response consistency or variance, right? They have a variance of 17 when they should be below 10. It looks like they have not necessarily a reduced power, but certainly a delayed P300B, and definitely not a healthy baseline big peak that we're looking for. So I am paying attention to this P300B. When I look at their theta-beta ratio, I see that this is a high score. It's above the reference range. So that is certainly a biomarker of ADHD. And then when I look at the head maps, I'm seeing high power in this frontal-central region in my theta range. And there's a little key down here. Remember, we're looking for high power red in our theta range, 4 to 8 hertz. Sure enough, that's one of our biomarkers. So my conclusion here is that this is likely a case of ADHD, and this patient is probably going to respond well to stimulants because this is the theta subtype of ADHD. That means stimulants can help. Now, let's talk for a second about why stimulants might help this patient. They have too much of this slow wave activity, right? So stimulants are going to perk the brain up into creating more of their resting state and even active brainwave activity. So stimulants use, it's a little counterintuitive. You might think, oh, stimulants are just going to make these heads more red. Well, no, these are slow waves. We're making too much of the slow waves. So stimulants is going to wake the brain back up. We're going to go back to normal amounts of our slow waves and then make more of these fast waves that this patient has a little bit of blue heads in our fast frequencies. Okay, next case study, a 14-year-old male. He's feeling defiant and irritable. When I look at my response metrics, I have really high variance and I have high omission and commission errors. So these are really classic ADHD behaviors. When I look at my P300B, I see a reduced power and a delayed speed. So that could be related to ADHD. When I look at my theta-beta ratio, though, I see that I'm not quite exceeding the reference range. And if you'll note, this report is showing a different reference range than our previous report we looked at. That's because this patient is 14 and the last patient was 20. So remember, the reference range shifts depending on how old the patient is. Lucky for you, eVox does this automatically, so you don't have to go and look up what the reference range is for your patient's age. We do that for you. But I'll note that this patient is creeping up to the maximum of that reference range, but they're not quite there yet. But when I look at my theta range, I do see high power in this frontal-central region. So this does look like an ADHD case, and I do think this patient will respond well to stimulants. Next, we're going to look at a 20-year-old male. Looking at my response metrics, I see that this patient has a high variance. They also have a pretty delayed response speed, something that I am keeping an eye out for because this is a 20-year-old. He should be pretty fast with hitting the button, and he's pretty variant. So he's definitely having some behavioral symptoms that he's worried about. When I look at my P300B, I don't necessarily see reduced power, but I do see a very significantly reduced speed. And this isn't really a clean ERP waveform. So and also his P300A isn't a great waveform. So he might be having some working memory, sustained attentional problems. And he also might have problems just paying attention to a stimulus at the onset as well. When I look at my theta-beta ratio, this is a very high score. So that is making me think ADHD. And then when I look at my head mass in this theta range, I'm seeing high power in my frontal-central regions. So I'm going to conclude yet again, this is likely an ADHD case, and this person probably will respond well to stimulants. Now let's look at a case study of a 55-year-old female. Now, we knew coming in that this person had long-standing ADHD, but she just felt like her medication wasn't helping her symptoms at all. So we look at her response metrics, and she's actually performing behaviorally compared to normal controls. She's not doing too bad there. And we look at her ERPs. Looks like her P300B power is okay. Her speed's a little bit delayed. That might be causing some of her symptoms. When we look at her theta-beta ratio, it's not high, but doesn't mean it's not ADHD, because when we look down here, we're looking in remember our second type of ADHD is in the beta range. So high power in a frontal beta, and that is classically what's defined here. I don't have the raw EEG snapshot here, but if we look at that, we would also see beta spindling for this patient. So yes, this is a case of ADHD. Her initial diagnosis wasn't wrong, but this is the beta subtype of ADHD. She is not going to respond well to stimulants, so that's why her medications haven't been helping. She's been coping well enough. Her behavior is not too far off. She does have some, self-reported concerns, but the reason why stimulants aren't working is because she's the beta subtype. So that's why looking at brain-based biomarkers can be really helpful when you're making a treatment plan. And we look at another case study of an 18-year-old male. He's coming in, he's not very variant compared to controls, but he does have some delayed speed. So I'm kind of concerned about that. For an 18-year-old male, he should be performing pretty quickly. Now, when I look at my ERPs, power for P300B isn't highlighted in red, but remember, we're supposed to compare P300A to P300B for power, right? So here, power is 41, down here it's 21. So we've reduced half of our power for the P300B. Now, the algorithm didn't trigger 21 as being too low, because for anybody else, 21 might be an okay score, but for this patient, it's very low. So I'm very concerned about his P300B power, and that is a biomarker of ADHD. When I look at my theta-beta ratio, it's not high, but when I look at my beta frequencies, I see high power in frontal locations, and that's classic beta subtype of ADHD. So this is a case of ADHD, and it's the beta subtype, so I don't think I'm going to recommend putting this patient on stimulants. Instead, I might take a neurofeedback approach. All right, we've made it through our presentation for today, and we're going to finish up with a quick knowledge check. So if you're still with me, try and answer these questions on your own before I reveal them. So theta-beta is a measure of what? Well, remember, it's not directly a measure of ADHD, because there are a couple different ADHD subtypes, but it is a measure of inattention, and that's technically the FDA definition of it, a measure of inattention. Now, what is the classic ADHD profile we're looking for? Power, remember, we're looking for red, so that would be high power. Location, we're looking for frontal-central. And frequency, our classic profile, about 85% of patients have this profile, is in theta, that 4 to 8 hertz range. Now, patients with this classic theta profile do or do not respond well to stimulants. They do. Now, we're looking at our ERPs. Is it P300A or P300B? That's a biomarker for ADHD. P300B. High reaction time variability is reflecting what? What does it mean when somebody has really high variability in their reaction time? It means they're having attention lapses. So it's not that they can't attend to something, it's that they can't sustain attention on a task. And some ADHD patients might present with high power in frontal regions of which bands, which frequency bands? This is our other type of ADHD we're interested in. It's the beta band. And we see our beta subtypes of ADHD. We know that they don't typically respond well to stimulants. All right, so that's it for today. Thank you so much for joining. If you have any questions you'd like me to follow up with, shoot them my way and I can respond via email. And I appreciate you spending your lunch hour with us and learning how to use EEG brain-based biomarkers to recognize ADHD. Bye.